Just one other question is, so first visit, you think patients should be on anticoagulation, don't like consider their rate or anything?
It's, well, no, I'm saying think those two,
rate.
right, but always the stroke risk. Now that's an interesting question because we have really 4 classifications of AFib. There's that first episode, and then there's the paroxysmal, comes and goes, then there's the persistent, where they're sort of stuck in it without us doing something to help get them back, and then there's the permanent where they are just in it, and maybe that's because we've accepted that AFib is okay for them with rate control. So that first episode ever, we don't have any good evidence that says we need to anticoagulate, we need to put them on rate or rhythm pills. If somebody came into the emergency department, we could theoretically just cardiovert them and send them home and see when the next episode happens. But I will say, if somebody pops into your office for their annual checkup and they're in AFib, well, that's a different story because they didn't know, and so you can't rely on symptoms to tell them. But we do see people who come into the hospital, say, when they've had surgery, like cardiac surgery, or they've had a pneumonia, a chest infection, and that seems to trigger an episode. We don't typically put them on permanent treatment for it. But if you've got somebody who first visit, but AFib you think this is an issue, yeah, if they qualify based on CHADS-2 scoring, we would recommend anticoagulation.